speaker, chairs, and the wonderful audiences in different parts of the world. Welcome to the ACNS webinar. The speaker for the first session today is our honorable guest from India, Professor Natarajan Muthukumar. Professor Muthukumar is the professor of neurosurgery at the Devados Hospital, Madurai, India. He was the former professor and the head of Department of Neurosurgery at the Madurai Medical College, India. He was the former secretary and the CME coordinator of the Neurological Society of India. We are extremely honored to have him today at our webinar, and he'll be talking about pediatric CV junction anomalies, lessons learned. The speaker for the second session of today is our honored guest from Brazil, Professor Tiago Cavate. Professor Tiago is the consultant neurosurgeon at the Hospital de Cirurgia Arachnoid, Brazil. He's the founding member of the Brazilian Society of Pediatric Neurosurgery and associate member of European Society for Pediatric Neurosurgery and ISPN. We are extremely honored to have him today at our webinar, and he'll be talking about the management of pediatric arachnoid cysts. So the chair for the first session today is our honored guest from Germany, Professor Consiglio Di Rocco. Professor Di Rocco is the director, Pediatric Neurosurgery, INI International Neuroscience Institute, Hanover, at Otto von Guericke University, Germany. He's also a consultant in the Department of Pediatric Neurosurgery, Catholic University Medical School, Rome. He was the past chairman of the Education Committee of the World Federation of Neurosurgical Society. He was the chairman director together with Professor Chox of the International Master Course of Chinese Pediatric Neurosurgery, Beijing United Family Hospital and Clinics and Capital Medical University, China. He was the past president of the ISPN. He has written several articles in reputable journals and book chapters. He's also the current editor-in-chief of the prestigious journal Child Nervous System. We are extremely grateful to him for accepting our invitation to chair the first session of today's webinar. The chair for the second session of today's webinar is our honorable guest from India, Professor Suhas Udanyakumaran. Professor Suhas is the professor in the Division of Pediatric Neurosurgery, Pediatric Craniofacial Surgery at the Amrita Institute of Medical Sciences, Amrita University, Cochin, India. He completed his specialization in neurosurgery from the King Edward Memorial Hospital, Mumbai, and thereafter his sub-specialization in pediatric neurosurgery at the Dana Children's Hospital, Tel Aviv University, Israel. He has more than 50 international publications, the peer-reviewed journal, chapters, and number of international conference presentation. He's also involved in multiple research projects in neurosurgery in association with the Amrita Center of Nanoscience and Molecular Medicine. We are extremely grateful to him for accepting our invitation to chair the session of Professor Tiago Cavate. On behalf of the Education Committee of the ACNS and the President, Professor Kato, I would like to welcome both the speaker and the chairs and the audiences to this online platform of ACNS webinar. A warm welcome to our colleague from China, and we are extremely thankful to Professor Zubin for broadcasting this webinar on the WeChat channel. Dr. Ben and Professor Raja are co-hosting this event today with me. And with that introduction, I would like to hand over this online podium to our first chair, Professor Consiglio Di Rocco. Professor.
Good morning to everyone, and I'm glad to introduce Professor Muthukumar to this not easy task to illustrate the great variety of malformation, congenital malformations, and acquired lesions over the craniovertebral junction. All of you know that we can have alteration of the occipital sclerotome. We can have a malformation of the odontoid process. We can have an alteration in development of these structures, and those that are interested in pediatrics know all this complex syndrome like Down syndrome, for example, that is quite diffuse, the Paget disease, the disease that comes from endocrinological problems like hyperparathyroidism, achondroplasia, Conradi syndrome, morchio. So now, and also the tumors. So there is a really great variety, and I would not have been so happy in the place of Professor Muthukumar because he has a really huge task to do on this. And also not to forget, we have to deal with the consequence of these anomalies that can involve nervous structures, can involve the circulation of the cerebrospinal fluid, so to deal with hydrocephalus, and we obviously can imagine how much problem can be generated from the difficulty of the diagnosis, the difficulty of planning what to do, and finally the difficulty to make this operation that are not so easy, especially in children that have to develop. So you have not to deal with the states, a fixed status, and but also to prevent what can happen with the development of the children. So, Professor Muthukumar, please start your lecture. I'm very eager to listen to you.
Good evening. At the outset, it's my pleasant duty to thank ACNS, Professor Yoko Kato, Dr. Raja, Dr. Liu, and Dr. Ben for this opportunity to share some of my thoughts with you today. And special thanks to Professor Diroko, whom I have always looked forward. He has been a role model for many pediatric neuroscientists throughout the world, and it's an honor to have him as the chairperson for this particular session. Today, I'll be talking about certain lessons which I have learned by treating craniovertebral junction anomalies. Obviously, it is not possible to cover the entire spectrum of anomalies during a 30-minute lecture. So I decided to confine myself to certain areas. So the photos and videos that are shown in this presentation have been with the consent of the patients or their parents. In this lecture, I intend to cover four broad areas. How is pediatric spine different from the adult spine? And what are the differences between children and adults as far as the pathological types are encountered? What are the technical issues of fixation of CV junction in the pediatric age group? And what are the long-term consequences of spine fixation in children? Now, the issues in pediatric CV junction fixation is that the osseous structures are very small and they are incompletely ossified. In addition, the ligaments are lax and the capsular joint capsules are lax, muscles are weak. And unlike adults, children have a lot of syndromic craniovertebral junction anomalies. And unlike adults, the injury pattern is also different in children. And then in children, the complication of using external brace is also a little higher than in adults. So we need to understand that the spectrum of pediatric age group is different. As far as spine is concerned, the pediatric spine continues to ossify until the age of 8 to 9. So many people have divided the pediatric age group into three groups as far as the spine ossification is concerned. Until 9 years is considered to be immature. Between 14 and 16 years, the spine reaches an adult configuration. Between 9 and 12 years, it is of an intermediate nature. What we need to understand is that the stability of the spine depends not only on the bony structure, but it also depends upon the ligaments, capsules, and the muscles, which are little underdeveloped in children. Now, the issues in pediatric CV junction fixation is that first, let us deal with the disadvantages. The disadvantages are that, unlike adults, the osseous structures are small, and in very young children, say 2-3 years of age, these structures will be cartilaginous. So if you are going to say use a titanium cable, for example, in the posterior arch, if you are tightening the titanium cable in a 1.5-year-old child, it will cut through the posterior arch. So the metallic instrumentation, in addition, metallic long-term fixation of the pediatric spine, you are going to fix a growing spine. So it will have an effect on the growth of the spine. That we'll discuss towards the end of the lecture. But then, when compared to these disadvantages, there is a specific advantage. Unlike adults, children have a greater tendency to diffuse. Therefore, the incidence of non-union is slightly lesser in children than in adults. I intend to discuss three broad areas in today's lecture. The unique developmental anomalies known as the broad less segmentation anomaly, And in children, skeletal dysplasias such as Marquio's, mucopolysaccharidosis, osteogenesis imperfecta are very common. And I'll also deal with the injury patterns, an example of an injury pattern that is different in children than in adults. Let's start with pro-atlas segmentation anomalies. Pro-atlas segmentation anomalies are developmental anomalies of the CV junction due to defective resegmentation of the fourth occipital scleroderm. The pediatric neurosurgery community came to be aware of this very important entity thanks to certain two seminal publications, first by Anomalies in Neurosurgery in 2009, another excellent publication about the embryology of the child's nerve of the craniovertebral junction by Dashking Pang and Thompson in child's nervous system, of which Dr. D. Rocco is the editor. Now, I'll just present you certain, highlight the various types of pro-atlas segmentation anomalies by using case examples. This 19-year-old male came to us with cervical myelopathy. Our radiograph showed atlantic axial dislocation with basilar imagination, and the MRI showed a ventral brainstem compression with the horizontal clivus, assimilated atlas, tonsillar ectopia. CT showed a horizontally oriented clivus. The anterior arch was fused to the clivus. The odontoid is invaginated, and there is an accessory ossicle between the horizontally oriented clivus and the odontoid, as shown by the red arrow. Now, this patient was placed under intraoperative action. We did an occipitocervical fusion with crossing C2 intracranial screws because we found in this particular patient the C2 isthmus was not large enough to take a screw. And we also placed lateral mass screw in the subaxial cervical spine, namely the C4 and C5. And if you see the image on the right side, we compare the pre-op and post-op. There's a descent of the odontoid, which means the ventral brainstem has been decompressed. And if you see the red arrow between the pre-op and post-op, it shows the increased space between occiput and C2, which shows that the realignment has taken place. The next example is a 19-year-old female who presented only with torticollis and mild cervical myelopathy. Her imaging showed basilar invagination, clipper field anomaly, and cervical canal stenosis. This patient also had a CT showed a basilar invagination. There was a clipper field anomaly. There was aplasia of the partial aplasia of the atlas. And if you notice the coronal images, there is hypoplasia of the occipital condyle on the right side. And there is a aplasia of the atlas, lateral mass of atlas on one side, as a result of which the C2 is directly articulating with the hypoplastic right occipital condyle. And this is responsible for this patient's torticollis. So this patient was placed under intraoperative action, and we did an occipitocervical fusion. And to deal with the cervical stenosis at the level of clipper field, we did a cervical laminectomy. And this is the left is the pre-op, right is the post-op, which shows the descent of the odontoid, and the yellow arrow points to the increased space between occiput and C2, which is an evidence of distraction. Now, case number 3 is a 14-year-old male who presented us with quadriparesis following a trivial trauma while playing. His radiograph showed atlantic axial dislocation, and the MRI showed significant compression of the cervicomedullary junction with intramedullary signal changes. But in this particular patient, the CT showed what is referred to as a dystopic os odontoideum. It's important to remember the os odontoideum is of two types. The common type we see is what is referred to as the orthotopic os odontoideum, which moves with the anterior arch. But here, this is a rarer variety known as the dystopic type of os odontoideum, where the os is fused to the basion, namely the lower end of the clivus. This is due to, once again, due to defective resegmentation of the fourth occipital scleroderm. So in this patient, because the pathology was due to atlantic axial dislocation, we performed a Goel-Harms fusion, and the lower images show the implants in situ. Case number 4 was a 10-year-old male who presented us with the torticollis and quadriparesis. In the MRI showed a compression at the C1, C2 with intramedullary signal changes, and sagittal CT showed a basilar imagination with atlantic axial dislocation. And the coronal CT showed a hypoplasia of the occipital condyle on one side. On the same side, the patient also had a aplasia of the lateral mass of atlas, both of which are responsible for the patient's torticollis. Now, this patient first underwent an antecervical procedure, which failed because of the cage migration. Second, on a few days later, we went in posteriorly. We did a posterior cervical occipitocervical fusion supplemented with the rib grafts. The images on the right, the pre and post-op, showed the descent of the odontoid, which means the compression of the cervicomedullary junction has been relieved. Now, case number 5 was a slightly older female. She presented with gait difficulty, cerebellar and pyramidal signs. The MRI showed ventral brainstem compression, tonsillar ectopia, and cervical syrinx. And her CT showed a marked platybasia. And if you notice, the basic occiput is hyperplastic, and there's a retroflexed odontoid, which is compressing the cervicomedullary junction. And in this particular patient, we place the patient on intraoperative traction, expose the Atlantic axis joints, denudal joints, place the largest spacer which it will accommodate in this space, which is just foramen spacer, and then followed it up with a C1 C2 fusion. Generally, this should have been sufficient to decompress the ventral cervicomedullary junction. Because the patient also had a Chiari malformation, we decided to do just a bony decompression, limited bony decompression of the foramen magnum without duroplasty. And the images are shown here. Post-operative images show the upper images show the implants in situ. The lower images, the pre-op and post-op show the descent of the odontoid and the foramen magnum decompression. And this is the left image is the pre-op, which shows the significant ventral brainstem compression with cervical syringe. The right is the 1 month post-op, which shows the anterior subarachnoid ventral to the cervicomedullary junction is opened up, which is an evidence of decompression. And within 1 month, there is complete disappearance of the syringe. The patient also clinically improved. And the T1 images show the tonsillar ascent when compared to the pre-op. Now let's go to the next topic of skeletal dysplasia. The most common skeletal dysplasia, which I have encountered in my practice, is Margios, that is type 4 mucopolysaccharidosis. It is an autosomal recessive condition due to mutations of the GALNS gene, which encodes N-galactosamine 6 sulfatase. Due to reduction of this enzyme, this results in faulty catabolism of keratin sulfate and chondroitin sulfase, which accumulates within tissues. Now, the problem with Margios Bracelet, predominantly it appears to be an orthopedic disease because there are significant skeleton and joint abnormalities. But it's important to remember the other systems are also involved, and spinal cord compression is one of the reasons for disability in these particular children. And as neurosurgeons, we need to remember that these patients will also have cardiac disease, respiratory disease, impaired vision, hearing loss, dental problems, and hepatomegaly, some much which can cause anesthetic problem, as I'll be informing you later. Now, this first case is a 12-year-old male who presented with spastic quad versus shock neck, a pectus carinatum, which basically means pigeon chest. And she had contractures of the lower extremity and corneal clouding on ophthalmic examination. And this is the MRI which shows the odontoid hyperplasia, Atlantic axial dislocation, the significant compression of the cervicomedullary junction, and there is anterior weakening of the thoracic vertebra, resulting body is referred to as a bullet vertebrae. That's a very classical of a Margios disease. And if you see the CT, this is C1 level, there is a bifid anterior arch, there is also bifid posterior arch. Basically, this is a bipartite atlas. So this is the intraoperative photograph which shows the bifid posterior arch, and the lateral mass has also been exposed. We did a classical Goel-Hams fusion for this particular patient. Retrospectively, we realized that these are the post-op images which show the implants in situ, and the post-op axial and sagittal CT which shows all the screws are in place. The patient did improve, and that's the patient 2 weeks post-op. The abnormal posture of the patient is due to the contracture of the lower extremity. Soft tissue contractures are also, and joint deformities also known to exist in patients with Margios disease. This patient underwent a soft tissue release for contracture a few months later. Now, this case number 2, from the previous case, I learned a lesson, because in the previous case, I realized that I had fused the C1 and C1 was bipartite basically. So in between the two rods, I should have placed a horizontal cross connector. However, the patient had improved, so I didn't want to go in again. So this patient came a few months after the first patient. This 6-year-old female was bedridden with spastic quadriceps. She had a short neck. There was no positive family history. And her radiograph showed Atlantic axial dislocation. And the CT, the other radiograph showed classical bullet-shaped vertebra. That's so classical of a Margios disease. And this is the CT which shows a bifid atlas. Like the previous case, this patient also had a combined anterior and posterior arch bifid, which basically means the atlas is bipartite. It basically means the two halves of the atlas are separate. So from the lesson I learned from the previous case, this time, this patient also had a cervicomedullary compression with significant intramedullary signal changes, which are responsible for a bedridden state. And that's the intraoperative photograph which shows the bifid posterior arch of atlas. From the previous case, I realized that it is necessary to put a cross connector. So in this particular case, instead of doing a classical Goyle-Harms fusion, what I did was we put a transarticular C1C2 fixation. Because the two halves of the atlas were separate, we placed a horizontal cross connector between the two transarticular screws. To the best of my knowledge, this has not been reported in the literature. And as metal fixation alone is not sufficient, we generally supplement it with rib grafts. In pediatric age group, I tend to prefer split rib grafts, which is what we did in this patient. Those are the posterior images which show the transarticular screws, and the post-op CT scan which shows the correct positioning of the transarticular screw. This is a patient, a bedridden patient, was able to stand and walk with support 2 months post-operatively, and about a year later, he was able to walk. And this is a third case, which is probably one of the most difficult cases of Marcus I have dealt with. This is a 6-year-old male, the second child born to consanguineous parents. He had spinal deformity since birth. He had spastic quadripartisis, short stature, short neck, pectus carinatum, and all other classical features of Marcus disease. Now look at his profile picture. He has a lot of skeletal deformities. He has practically no neck, and he has a significant thoracic kyphosis. He has a significant pigeon chest. His abdomen is protuberant. All these will lead to a lot of intraoperative problems, as we shall be seeing later. And these are the images which show the bullet vertebrae, which is classical of Marcus disease. And the sagittal CT shows the classical bullet vertebrae. And like the previous two cases, this patient also had a combined bifid anterior and posterior arch of atlas. So this is the odontoid hyperplasia is almost always universal in patients with Marcus disease, as shown in this particular case. Now, this is the 3D image which we had incidentally taken, which proved to be very useful during surgery, as we shall be seeing later, which shows the bifid posterior arch, and there's a large bifid C2 spinous process with the thick lamina. The significance of it we'll see shortly. So this is the MRI image which shows significant compression of this apicomedullary junction, which was responsible for a spastic quadripartisis. But very important to know that some patients with Marcus will have kyphosis at the cervicothoracic junction and kyphosis at the thoracolumbar junction. In this particular patient, it was not causing significant cord compression, and therefore this was not treated. But at a later stage, this can become symptomatic at a later stage. So this patient was operated intraoperative neuromonitoring. Notice the thoracic kyphosis, extremely short neck. And this patient, my plan for this patient was, because it's a very difficult case, I went in for 3 options. My option A was to use a transarticular screw fixation, as I did in the previous case, which I anticipated to be difficult because of the short neck and thoracic kyphosis. My option B was to do a C1C2 fixation with the horizontal cross connector between the 2 rods, which I thought I would be able to do. In the rare event of not being able to do these 2 procedures, I had opted for an occipitocervical fixation. What happened intraoperatively was all the 3 options failed. Now, transarticular C1C2 fixation could not be done because the neck was very short, because of the thoracic kyphosis. I could not get the angle to place a C1C2 transarticular screw. As you know, this child has a significant pigeon chest, very short neck. When you keep the child in prone position, there is an intrathoracic pressure increases, and there's a significant bleeding from the C2 venous plexus, which we control with great difficulty, as shown by the hemostat here. And individually, before surgery, I had measured the dimension of the subaxial lateral masses. So, and in spite of that, when I tightened the rod on the right side, all the subaxial lateral mass was pulled out. That all the 3 options I had when I had planned preoperatively failed. So then we went back and looked at the images again. Then I realized I had read sometime back that in children, the C2 lamina is thick enough to take a screw. So eventually what we did was we put a C2 translamina screw on the one side and placed the part screw on the other side and supplemented it with rib grafts. Those are the intraoperative images which shows the occipitocervical construct, and thus the post-op CT which shows the left side C2 part screw, and you see even in a 6-year-old child, the lamina is thick enough to take a 10 mm, 3.5 mm screw. which is entirely within the confines of the two cortices of the lamina. This is a very good option, about which I'll be discussing towards the end. Now, this is the final construct, and this is a patient 1 year post-op, and his gait is a little abnormal because of the joint deformities. Otherwise, his pyramidal signs are significantly improved. Now, a few points to remember about these Marquez diseases. In large study of Marquez disease, 325 patients, it was noted more than 50% of patients will have cord compression, which is one of the main causes of the disability. And most common site of compression is the CV junction, followed by the cervicothoracic and thoracolumbar junction. And it is also important to remember that the prevalence of compression increases with age. A beautiful article about the cervical spine in Marquez disease was published by Girish Solanki from Birmingham Children's Hospital. It shows that odontoid hypoplasia, as in our experience, is almost always the norm in Marquez disease than the exception. And in the cases which I have shown you, there is no retroodontoid accumulation of this keratin and chondrite sulfate, but there are certain patients where, like in adults with rheumatoid disease, there may be a retroodontoid soft tissue, which is due to in this particular instance, due to accumulation of glycosaminoglycans. And the pathology, the instability may also be due to the laxity of the transverse ligament. And there are clear-cut relative and absolute indications as shown by this study in Journal of International Inherited Metabolic Diseases. The relative indications of the presence of pyramidal signs clinically, the absence of CSF around the spinal cord in the MRI, the absolute indication being the presence of weakness or myelomalacia. The three cases which I have shown have patients had absolute indications. I have several more cases where there is no significant clinical sign under follow-up without any clinical evidence of myelopathy who are under follow-up. Now, there are certain guidelines how to deal with patients with Marquez disease. Surgery should be done under intraoperative monitoring because these children have a very high risk of deterioration, because as you can see, all the three cases I showed, there is significant compression. So even slight manipulation of the during positioning, especially during position, the potentials can get lost. And changing from supine to prone position is very difficult. We should be very careful. It's preferable to place the bolsters on the lateral side, because the pigeon chest, what will happen is it will not only increase when the patient is placed in the prone position, it will increase the intrathoracic pressure and lead to engorgement of the veins in this C2 venous plexus, which will make the surgery very difficult. And it will also lead to compression of the cardiac chambers, which can lead to anesthetic problems. And these children also have a lot of upper airway abnormalities, so intubation can be very difficult. So it requires an experienced pediatric anesthetist, probably who is experienced with fiber optic intubation, to intubate these patients. As far as spine in Marquez disease is concerned, sudden death is known to occur mainly because these patients have odontoid hypoplasia. Even a trivial trauma can cause a subluxation and lead to sudden death, to the extent that I'm sure Professor Dirocco should be knowing that in early 90s, Professor Alan Kirkard in his publication, used to suggest that every patient with Marquez with the radiological evidence of Atlantic axis dislocation should undergo a prophylactic fusion. Of course, those concepts have changed over a period of time. And as you know, that we make a diagnosis of Atlantic axial dislocation mainly based on the atlantoid dense interval. And because in this patient, the dense is hypoplastic, the best way to make a diagnosis will be to do an MR, preferably in flexion and extension. And it's extremely important for surgeons who operate on this patient to know that just operating is not enough. This patient should be followed up for a long period, because 40% of the patients, or maybe even more, may develop problems, especially at the cervicothoracic junction or at the thoracolumbar junction, as I've shown in the third case. And asymptomatic kyphosis can become symptomatic at a later date, and sometimes even in adulthood. Now, these two publications deal with the incidence of cervicothoracic compression. In this particular publication, 20% of patients who had a CV junction instability also had a cervicothoracic compression. In another publications, among the 4 patients, 2 patients had cervicothoracic compressions, and these patients are sometimes treated concurrently, but in my opinion, it should be treated at different stages, because these 2 are in very young child. There's a major surgeries. And this is what I would like to highlight, that this is the MRI of the 3rd patient. Notice in this patient, there is no compression as such, radiologic compression as such, but because there is a kyphosis at the cervicothoracic and thoracolumbar junction, as the child grows, it can cause compression, and either one or both of these can cause myelopathy at a later date. So preferably, this patient should be followed up, preferably in a skeletal dysplasia clinic lifelong. As far as mortality in Marcus disease is concerned, this study, a population-based study in UK, has shown that from 1980s to 2000s, the mortality has significantly decreased, mainly because the treatment strategies have significantly improved, which has improved the quality of life of these patients. Now, this is preferably the neurological evaluation should be for patients with Marcus should be done at the minimum interval, the maximum interval of 6 months. And the radiological evaluation should focus on stenosis, instability, and cord compression. And annual MRI of the spine is necessary, with a special focus on the CV junction, cervicothoracic junction, and thoracolumbar junction in suspicious cases where there are borderline pyramidal signs, because in a young child it's very difficult to elicit some pyramidal signs. So if you have any suspicion, it's preferable to take a flexion extension MRI, which will be much more useful than a static MRI. Next, we go to a much more rare and difficult condition to treat, namely osteogenesis imperfecta. This is a hereditary condition due to abnormality in type 1 collagen. This is due to mutations of the COL-A1 and COL-A2 genes. And the physeal osteoblasts cannot form osteoids. Initially it was divided into 4 types, subsequently 3 more are added. There is an autosomal dominant and autosomal recessive form. The recessive form is supposed to be more difficult, more severe. And in this particular condition, we need to understand what we see in this patient is not a basilar imagination. It is a basilar impression, which is because the base of the skull is softened, as a result of which the cranium, the foramen magnum infolds inside, bringing along with it the odontoid, which is invaginates into the foramen magnum. So this is a basilar impression, which is different from basilar imagination. What happens as a result is the volume of the posterior fossa is decreased, which can lead to cherry malformation and syringomelia, or it can lead to distortion of the brainstem, and it can very often lead to hydrocephalus. Now, this is a 20-year-old male who was under treatment with the senior orthopedic surgeon of our hospital. It's a known case of osteogenesis imperfecta. He had a history of multiple long bone fracture. He was evaluated for scoliosis. And this is a CT which shows a significant platypesia. Basically, the C1 anterach is adherent to the basion, significant basilar imagination. There is infolding of the posterior margin of the foramen magnum. Significant kyphoscoliosis is seen. And this is the MRI of the patient, which shows a significant this syringomelia extending up to the thoracic guard. And there's a borderline ventriculomegaly. This patient had features of a arrested hydrocephalus, and nothing was done for this patient. I'll discuss about it later. The next case is a 12-year-old female who was also a known case of osteogenesis imperfecta under treatment with our senior orthopedic surgeon. I was called in to evaluate this patient during one of those admissions. She had 2 episodes of seizure. At this time, we did. She also had no deficit except macrocrania. And this is the CT, which shows a significant platypesia. There is a significant basilar impression. And you see here, there is an infolding of the foramen magnum. There is a medialization of the occipital condyle, which the literature calls as a Darth Vader skull. For those who are familiar with Star Wars trilogy, they will know about the Darth Vader. And this is the MRI of the patient, which shows significant platypesia and basilar impression with kinking of the cervicomedullary junction. But notice this patient had no intramedullary signal changes. There's still some subarachnoid space visible, and she had no myelopathy. Hence, this patient was not treated. This patient also had macrocrania and features of arrested hydrocephalus. Now, it is important to know how common is basilar impression in osteogenesis imperfecta. Studies have shown the incidence of basilar impression will be anywhere between 21 to 28%. And there's also a high incidence of CV junction anomaly, which can be as high as in 1/3 of patients. Now, is surgical intervention is required in these two cases? When these two cases presented one after another within a short period of time, I sent these images to one of the senior pediatric neurosurgeons who was at that time in North America, and he counseled me not to operate on these patients because it's extremely difficult to operate. And I also did a literature search, which there's a wonderful article by Arnold Meneses. He had treated 28 patients with osteogenesis imperfecta between 1985 and 1995. At that time, he had done a transoral decompression followed by occipitocervical fusion. The most important take-home message is that in spite of this surgery, in the hands of a very experienced surgeon like Meneses, the deformity progressed despite fusion in 80% of the patients. So therefore, after that, they resorted to bracing with a modified form of Minerva jacket, which decreased the rate of progression of basilar invagination. And Meneses also highlighted that adolescence is the age group which is the highest risk for basilar invagination in patients with osteogenesis imperfecta. Now, how to manage children with osteogenesis imperfecta, because as neurosurgeons, we don't come across these cases frequently. So when such a case comes in, we are in a quandary how to manage this. So important to know that one of the recent publications has shown that before 6 years of age, it's preferable to have a cervical spine X-ray at least, or preferably a CT, and a whole spine X-ray, because that gives you a baseline so that which you can compare as the child grows. And a baseline MRI especially of the CV junction is also necessary, so that at a future date, if the patient is going to develop syringomyelia or some such compression, it will be helpful for us to take management decisions. Now we come to the third part of my lecture, which is going to deal with the injury patterns specific to the pediatric age group. Now, this is a 10-year-old girl who came to us with quadriplegia following fall from a height. And her MRI showed significant compression of the cervicomedullary junction with intramedullary signal changes. And her CT showed an odontoid synchondrosis fracture. Now, generally, odontoid synchondrosis fracture can be treated conservatively, except when it fulfills one of these criteria, namely when there is a displacement of more than 11%, when there's an angulation of more than 30 degrees, or there is clinical evidence of spinal cord injury. So our patient had fulfilled 2 of these 3 criteria. So we went in and operated on this patient. We did a classical C1 lateral mass C2 pedicle screw fixation. Those are the post-operative images which show the implants in situ. And this bedridden patient was able to stand and walk, and 3 months later, she was able to go back to school. Now, what about odontoid synchondrosis? The subdental synchondrosis between the dens and the body of axis does not fuse until the age of 7 years. But occasionally, this fusion may be delayed until adolescence. So it is a potential source of biomechanical weakness, especially because in children have a large head and they have weak musculature. When there's a flexion injury, what happens is that the synchondrosis slips over the odontoid. It's not actually a fracture. It's just like an epiphyseal injury of a long bone in a young child. It slips over the fracture. It is not actually a break in the bone. And the indications of surgery I have already described. Now, there are finally coming to certain technical issues in pediatric CV junction fixation. Now, I'll start with the technical issues in C2, which I think is a little more important than C1 lateral mass. If you remember, if we see this study, C1 lateral mass has a length of 15 to 16 millimeters, which can adequately we can easily place a 14 mm screw in a C1 lateral mass of a young child. The width is 7.5 millimeters, so you can easily place a 3.5 mm diameter screw. The problem comes with C2 because normally we place a C2 isthmus screw. Here, the average diameter in a child around 4-5 age, all those cases we have seen, is 2.8 millimeters only. But you look at this, the laminar diameter is average 4.5 millimeters and the length is 19 to 20 millimeters. I had incidentally read this article a few months prior to operating on one of the cases, and this saved me intraoperatively for the third case by using a salvage technique. Subsequently, I have used this as a salvage technique. I use translaminar screw only as a salvage technique when I am not able to place a C2 isthmus screw. But it's important to remember that there's one more publication which has also clearly shown that in young children, instead of a C2 pedicle or a isthmus, C2 laminar is much more suitable for a screw placement as shown in this particular study. Now coming to C1 lateral mass. The C1 lateral mass, once again, the entry point we use for an adult is different than in a child. Why? Because in pediatric spine, the junction of the posterior arch of the lateral mass is offset laterally. Now what we do is, we generally place a screw at the middle of the lateral mass of C1, which is usually where the posterior arch fuses with the lateral mass. In pediatric age group, this, especially in younger age group, this site of fusion joining where the posterior arch joins the lateral mass is little laterally offset. So if you use that as the point of entry, you are likely to go laterally and injure the vertebral foramen. And this is a figurative description, the how it joins the lateral mass in adult and in the pediatric age group. Now, next point to remember in the C1 lateral mass screw is, if you notice, the area pointed out by the red arrow is where we are going to place a screw. In young children, this may be very small. So if you are going to angle the screw a little bit, or if you don't place the screw properly, the screw will violate the atlantoaxial joint. So sometimes we need to drill the under portion of the lateral mass of the posterior arch of atlas. But when we do that, we need to remember right above lies the sulcus arteriosus, which contains the vertebral artery. Therefore, if we have to drill this area, we have to first isolate the vertebral artery, ask the assistant to keep a pen field under the vertebral artery, and then only drill. So it is extremely important to remember this technical issue, which I have learned by experience. The next issue is, in children, unlike in adults, the cortical bone is slightly thicker. What happens is, if you are going to directly place the drill will skive and move medially, skip and move medially and laterally. So it is always, both in adults and children, now I always take a 2 mm burr, perforate the posterior cortex, enter into the cancellous bone, and then start drilling. That is a it may appear to be a very trivial technical issue, but it can be life-saving for the patient, and it will avoid a surgeon a lot of stress. Now, the next point is, in children, sometimes it's extremely common to have troublesome bleeding from the venous plexus, C2 venous plexus. In adults, it may be acceptable. You can take your own time to coagulate, use hemostatic agents, but in children, especially in very young children, the blood volume, as we all know, is very less. So you cannot afford to have blood loss. So if it is going to bleed profusely, there is no harm in sacrificing quickly, cauterizing and sacrificing this C2 nerve root. But it's preferable to preserve the C2 nerve root, because at least on one occasion, one of my patients who was wearing a hard cervical collar, a Philadelphia collar, developed a pressure sore in the anesthetic area and the occipital region. So it's preferable, but if the bleeding is very profuse, if there is no other choice, there is no harm in sacrificing a C2 nerve root. Now we come to the most important last part of the lecture. What are the long-term consequences of fusing CV junction in children? Because when you fuse the spine in a growing child, it is going to have long-term consequences. And what are those consequences? The consequences what is referred to as a crankshaft phenomenon. Crankshaft phenomenon is described in adolescent idiopathic scoliosis by scoliosis surgeon. And because what happens when you fuse a growing spine, the portion of the spine grows, the rest of the spine growth is retarded, which leads to abnormal curvature. So it can lead to abnormal curvature, instability of the non-fused levels, and disturbance of the growth of the fused vertebra. There's considerable controversy in the literature as to whether crankshaft phenomenon occurs in the occipitocervical junction. There are some publications which say that it does occur. There are other publications which say it does not occur. But to my knowledge, there is no publication which has followed the patients for 10, 15, or 20 years. This is a publication, an old publication in Journal of Pediatric Orthopedics, where this is probably one of the longest follow-up of more than 11 years. They noticed that for every level fuse, the lordosis increased by 1 degree per year per fuse level. So what happens is, definitely when you fuse the occipitocervical junction, the subaxial cervical spine lordosis is going to increase, which might or might not become symptomatic. Now, these authors, on the basis of their radiological evaluation recommended that to avoid this, you should fuse the spine in neutral or slightly flexed position. You notice I have scored out this last sentence because I believe this is a misleading statement that should not be sent to the audience, because those who have done a lot of occipital-cervical fusion, instrumental fusion, will realize that you should never ever fix the occipital-cervical junction in flexion, because whether an adult or a child, especially in children, if you do it in flexion, it can lead to difficulty in swallowing. Sometimes it can lead to difficulty in breathing. There have been case reports in spine literature where the patient had respiratory difficulty. Immediately the patient had to be taken to the theater. And what happens is, even if the patient doesn't have that, the visual axis, if you fix in flexion, the visual axis will go down. So the patient has to extend his or her spine to maintain the normal visual axis. So this is probably not a good recommendation, which probably the reviewers of this article failed to flag the concern to the editor. But there are other publications, such as this publication, which shows that after a follow-up of significant follow-up of less than 5 years, they noticed there is no crankshaft phenomenon. But there are other publications such as this in the European Spine Journal. If you look at this figure, it is very impressive that the fused segment is not growing, especially the disc size is reduced when compared to the non-fused segment. And what is seen here is you don't see a normal cervical lordosis here. So obviously, when you fuse the upper cervical spine, there is an alignment of the lower cervical spine. The subaxial cervical spine is going to change. And this is what this particular publication by Murthy and Rajshekhar in 2009, Child's Nervous System, is one of the wonderful articles, unfortunately not widely quoted in the literature. They followed 14 patients less than 20 years of age, and they noticed in the younger patients, the angle lordosis increased by 15 degrees. 55% of the children had a significant increase of more than 10 degrees, which warranted removal of the occipital-cervical implant. At that time, they had used a contour tube, which was the usual practice in the late 90s and probably even in the early 2000s. So what happened is they removed the implant to prevent the progression of the cervical lordosis, and after removal of implant, the lordosis either stabilized or in some cases even reversed. So concluding, child is not a little adult. As in medical school, when we go to the pediatric department, the first thing they tell us is child is not a little adult. What they don't tell us as pediatric neurosurgeons we have to know is a neonate is different from an infant is different from a toddler is different from an older child, and an older child is different from a teenager. So all these age groups have different, the maturity of the spine is different, the anatomy is different, the biomechanics is different. A thorough understanding of the anatomy, the biomechanics, and the diseases that take place, we should be aware before operating on the craniovertebral junction in children. And before concluding, let me tell you that there are certain areas which I have deliberately avoided, like os odontoideum, whether to operate on a patient with incidental os odontoideum, and certain other soft tissue anomalies I have not included because that will I will be exceeding the allotted time. So I will thank you for your kind attention, and I'll happy to take any questions.
Very impressive. Congratulations. You are frightening all of us that are involved with this disease. And for the reason that you just said, we have not only to face with the malformation, but with the difficulty to operate and to predict the long-term result. And I don't know if there are questions from the audience.
So far, there's no question from the audience, Prof. I have two questions, Professor, if I could ask. Yeah, Prof, thanks for a very nice and fascinating lecture. I have two questions, Professor. You mentioned about traction just now in one of your case. May I know how do we perform traction in pediatric age group, especially those traction to perform traction?
Yeah.
Yes. And then again, do you have ever attempt a manual reduction intraoperatively, especially for the odontoid fracture just now? What is the risk, and is there any necessity to do the reduction, especially when you do a posterior decompression? My second question, Professor, What do you think that whether Chiari-1 malformation is due to CV junction anomalies? Thank you, Professor.
I'll take the second question first. Now, I have a separate lecture on Chiari malformation, why Chiari malformation is not a single disease entity. And that is a sort of provocative, controversial topic. And there are subsets of patients. For example, some of the CV junction anomalies, which I showed earlier in my presentation, they had retroflex odontoid, they had basilar invagination. Those patients, the volume of the posterior fossa is reduced because of the invagination of the odontoid. So what happens is, if you are able to bring the odontoid out of the foramen magnum and realign the cervical spine, that should be sufficient. But extending the same logic to a patient without a CV junction anomaly, I don't do that. I don't do that because I have seen patients with CV junction. I have treated plenty of patients with CV junction anomalies and Chiari malformation successfully with craniovertebral alignment. At the same time, only 1/3 or even less than that of my patients with Chiari have CV junction anomaly. And this is the same experience by leading experts in the field like Arnold Meneses, etc., even who have a lot of CV junction anomalies. So I certainly don't believe in doing a C1, C2 fixation for every patient with Chiari malformation. If there is a craniovertebral anomaly, I will certainly go and reduce that craniovertebral anomaly, and those patients, the Chiari will disappear. But for a patient with a Chiari without a CV junction anomaly, a routine run-of-the-mill Chiari, the run-of-the-mill Chiari one which you see, I don't think there is a role for C1, C2 fixation. Now, the first question is, how do you do a traction? I generally don't, in children, especially in children, I don't do resort to preoperative traction because children generally do not tolerate preoperative traction. So it is usually an intraoperative traction, and I don't use manual reduction. By manual reduction, I hope you mean that it is by pressure, by the pressure during surgery, which I generally don't do. What we do is we alter the head position. We ask the anesthetist to change the head position. If monitoring is available, monitoring should also be done after every time you change the head position. So that's how we do it. In children, generally, I do not do preoperative traction. I am aware that this halo traction is available in certain countries. We don't have that facility, therefore I don't do it.
I like that you use the word anomalies of a Chiari and not malformation.
Yeah.
Because I think the word malformation is confusing. It's not really a malformation. And the regress after correcting the bone malformation in the volume of the posterior fossa. But there is some space for bracing to delay the time of operation in very, very young children.
Yeah, certainly. I think bracing, especially for example, in patients with osteogenesis imperfecta, which I showed, if I had encountered those patients in a younger age group, probably bracing would have been an option. But I have encountered only the osteogenesis imperfecta patients I have encountered have been in the late teens or in the touching 20. So by that time, they had already, their growth had stabilized. There is no need for any, because their growth they had completed their growth. There is no need for bracing. I have read the literature regarding bracing in osteogenesis imperfecta. Even though Dr. Meneses says that with bracing, yes, had good improvement, there are a couple of reports in the literature which say, because these patients also have scoliosis, when you do bracing, the pressure on the ribs leads to rib fracture. So that is something in osteogenesis imperfecta. In other conditions, of course, there is a role for bracing. But what happens, Professor, in our country is that the compliance for external arthrosis is very low. And when you ask them to have a brace and ask them to come back, some of these patients do not come back, or they come back months or years later bedridden. So we don't, if there's an option to operate, if there's an indication to operate, we operate at the first possible time, provided there's an appropriate indication for it.
We have a time for another question. What about removing the implant? You mentioned that was suggested to remove the implant to impede further progress of posterior displacement of the column. So why removing the metallic disposal and leave the bone to act to fix only the bone.
That's interesting. This is, I'm extremely happy you asked that question, Professor, because I was planning to explain that, but I probably missed out explaining that. So what has happened is this is done by a center, one of the centers in South India, where this work was done. What they actually, it was published in Child's Nervous System. You are the editor of the journal. So what has happened is they've noticed that the lordosis of the cervical spine was increasing. Because the lordosis was significantly increasing, they went in and removed the implant. Normally, because the bony fusion has already taken place, normally what we expect is, because the bony fusion has already taken place, the removal of the implant should not alter the progression of the lordosis. Am I right? But what has happened is, the progression of lordosis has either stopped or has actually reversed. The explanation given by the author, which I strongly believe is correct, the explanation given by the author is, once you put a bone and it fuses with the host bone, after a period of time, it grows concurrently with the host bone. The growth is similar to the host bone. So it does not behave differently. It does not act like an implant. It behaves just like a host bone, which was already there. So it does not lead to further progression of abnormal curvature. That's a beautiful explanation given in Child's Nervous System by those authors. I presented this as this issue of crankshaft phenomenon in one of the meetings, and one of the authors was there. He sent me this article, and I was terribly impressed by this particular work.
Very impressed. Thank you very much. It was a very clear explanation, and you show very difficult case like the osteogenesis imperfecta as a morchio that it will be really difficult to treat, especially because they have other problems, and you have to deal with the expectancy of the families, because you can do very difficult operation that the child die because of a heart failure. So the family can be very deceived, and it's very difficult, I think, to have them understanding all the situation. It's very difficult, and I'm impressed from your dedication to this difficult children. Thank you very much.
Thank you.
Very, very nice lecture. If there are no other questions?
Yeah. Professor Suhas and Professor Tiago. Yeah, do you have any question, Professor Suhas and Professor Tiago?
Yeah, I was just wondering to ask Dr. Muthukumar, sometimes you have a very young, let's say a neonate and close to neonate coming up with C1 compression, secondary to C1, C2 Atlantic axis dislocation. So, I had once an opportunity to do a C1 laminectomy and wait for the child to grow beyond, and then land up with occipital cervical. That was some kind of a knee-jerk reaction that I did, but it helped the baby. And then I had to do an OC1, OC2 fusion later when the child became a complete infant, and when the bones were better. What do you think about this?
I think that's a viable option. And one of the things I have learned early in my career as a neurosurgeon, there is not much of guidance because not many people were doing CV junction surgery. So what I had done is, I have not operated on an infant as such. Maybe I would operate on a child around 18 to 20 months old. As the youngest child, I have operated for a CV junction anomaly. At that time, we didn't have implants. Obviously, even if implants were available, I don't think we would have been able to put implants in 18 months or 20 months old child. What I did initially was, I made a mistake. What I did was, at that time, there were stainless steel wires, not titanium wires. So I took the rib graft, and because you extrapolate, this is what I told at the end of the lecture, don't consider the child as a little adult, even don't consider the infant as an older child. These are different, because older child can have a nice rib graft with a cable fixation. 18 months, 20 months old child, you cannot do it. So without realizing, I had put the rib graft and tightened because the posterior arch, obviously cartilages is cut through. So I had to put an on-lay graft and place the patient. Subsequently, I changed. I discussed with a lot of other pediatric nurses around the world. What I did was, if such instances are very rare, because generally I treat patients with AAD generally around 4 or 5 years only, because less than 5 years is extremely rare for me. In my experience, at least, maybe a few cases only. If such a case comes, what I will do is I use a rib graft. I use a ethibond, and I believe there's a which is a non-absorbable suture, and I believe there is another which I used to fix the C1 and C2 using sublaminar wire, thread it subliminarly and place it, wire it, keep the rib grafts in place. But I believe there's another synthetic material which is like a tape which Dr. Pang had once told me. I forgot the name of that. And my orthopedic colleague also told me once that they use something for the ACL reconstruction. I don't remember the exact name. He told me that also can be used, but I'm not sure whether I think the stuff they use for ACL should be very big. I don't think it will be suitable for a young child. So but there's another substance, a synthetic substance, which is like a ribbon, which is non-absorbable, which Dr. Pang had told me some time back. I really don't recall that name. That can be done. So, but in that particular case, probably what he did was probably, as long as the patient has improved, the ultimate outcome is good.
Yeah, these children are very difficult.
Thank you. Professor Tiago, please.
Good morning, everybody. I really don't have questions about this presentation. That's so impressive, but because when you read about it, it's not so difficult. But for the real life, the case that we had here was very tough cases. And because here in my region in Brazil, we have some difficulty to explain for the families the reason for utilization of the grafts. And we don't have a lot of patients with mucopolysaccharidosis and other pathologies. Even for the KI, we have a lot of KI here. We don't have a lot of case of instability, cranial cervical instability. So congratulations, Professor, because the real life is a little different for the books.
Yeah, that's true. Because something which I would like to just highlight is I believe there is some regional variation in the incidence of craniovertebral anomalies. There's some reason probably in the Asia region. In Asia, for some maybe some genetic or racial reasons, craniovertebral junction anomalies are much more common. I don't know about mucopolysaccharidosis. I believe mucopolysaccharidosis incidence should be same everywhere. Maybe the incidence should be much higher than what I have seen, because in the North American countries and probably in places like Europe, probably Professor Rico will be able to tell us that they have special skeletal dysplasia clinics. So if you have a skeletal dysplasia clinic where all these skeletal dysplasia, mucopolysaccharidosis, achondroplasia, all these are treated, then you will have a large catchment population to follow and really know. Because now we are coming across only symptomatic patients. I'm sure there is equal number of patients who are asymptomatic. I have at least half a dozen patients with mucopolysaccharidosis whom I have diagnosed. They have some abnormality, but they don't have cervical myelopathy. I have not interfered with them at all, because just don't trouble until trouble troubles you. That's my policy.
Thank you, Professor Muthukumar and Professor Tiago, for the questions. Do you want to give any closing remark, Professor Di Rocco, before we move on?
Yeah. I think we're in perfect time. Like you started exactly at time, and the Professor Muthukumar did a very perfect presentation. So I think we can move on the other topic. Thank you very much, Professor Muthukumar.
Thank you to Professor Muthukumar and Professor Di Rocco. Now I would like to call upon Professor Suhas to call upon our second speaker, Professor Suhas.
As we had the introduction in the beginning, Dr. Tiago is a senior pediatric neurosurgeon from Brazil. He's going to talk about arachnoid cysts in children, the pediatric management of arachnoid cysts in children. And we know that arachnoid cyst in children, managing arachnoid cyst in children is a very challenging. The treatment choices at each of the locations are completely different. And of course, the outcomes of each of the locations are completely different. So this particular topic, and Professor Tiago would try to give us some more highlights of all these issues.
Okay, good morning, everyone. Yeah. Thank you again for the invitation. Professor Lee, and for the patients with Professor Raja with me. When he proposed to talk about management of pediatric arachnoid cysts, it's easy to talk about it because it's difficult to say something that it's completely right. When I saw that the factors was Professor Jihoko, for me it's a great pleasure, and I'm really happy because he is with us. Because there are a lot of things that we agree with him, and when we think about arachnoid cysts, we think like he in. Well, I don't have no fund or interest conflicts about we will talk about, and for some, just for you know what are we talking about. We live here in Brazil, in Northeast Brazil, in a region that we have resident service. We live in another part of the world. Our city, our state is called Sergipe, and our city is the main city in state of Sergipe that we know. It's a city in a lot of bits, but it's a city of 6,000 inhabitants, but we are responsible for 2 million inhabitants with a pediatric service, with 5 hospitals for these 2 million inhabitants that we can operate almost of the cases in pediatric neurosurgery. When was proposed for us talking about management of arachnoid cysts, I went to the PubMed, and I could observe that in the last 50 years, we have about 3,700 papers about management. And just in the last 10 years, we have almost the half of these papers showing that from the 20s, we have a change in the changement in the form to think about arachnoid cysts in pediatric population, because now it's not about to be or not to be arachnoid cysts. We know, but it's about to do or not to do, operate or not operate. Only if we operate this case, how can we make this case? So the surgical indication differ according to location. We need to choose when we have a clinical objective, technical objective, and experience, and we need to think about if we're talking about this is a benign condition or a condition is incompatible with normal life. Actually, I think that we are leaving something about this. I think the principal slide for this presentation, because I think we are during a second loop for the low knowledge evolution for the arachnoid cysts. In the 70s, we start to operate with shunts. Okay, shunts better than surgical microsurgery techniques, because after, principally for the profound arachnoid cysts, and after with the microsurgery techniques get better, we started to operate the spaces, and in the 20s, with the neuroendoscope techniques, we almost stopped to operate these patients by microsurgery techniques, and we start to operate almost everyone with neuroendoscopy. And there are good papers that was in the last 5 years or 6 years showing us that's not difference, clinical difference for evaluation if we do this case by shunt, by microsurgery techniques, or neuroendoscopy. It's obvious that I'm not talking about profound, suprasellar, quadrigeminal, but for the most common, fossa, median fossa, and cortical and ventricular, and posterior fossa. Now, we think that we are something like microsurgery techniques plus endoscopy techniques in the same time. And although all these techniques, the nodules evolution for the arachnoid cysts persists. For why we wrote a paper the last year explain why neuroendoscopy is not for all supratentorial intracranial cysts in children. Here in our country, I don't know if it's the same in your cities on your service. It's a tendency to think that everything we can make with technologies. If there is a very beautiful technology, we can make everything. But for arachnoid cysts, not everything is what it seems. And we start to ask why some patients don't get better, why some patients get better with the same cysts in different ages and the same techniques. It's not when we see this case with intraventricular arachnoid cysts, and in this case with temporal fossa, a medial temporal fossa, galaxy 3 or 4, it's not doubt for us that we can use the 3 techniques. In 2016, the World Neurosurgery published a very interesting paper about a systematic review and meta-analysis that we agree with that. We know that intracranial drainage is better than extracranial shunt for some cases, but when we think about clinical improvement, it's not doubt that for this type of cysts, we can use all the techniques. A little different when we think about the suprasellar cases, that the endoscopy technique is the better for us. And some challenge case like this the magnum foramen case, congenital, that we can use at least 2 techniques or 3 techniques, but it's again, it's if something has so many treatments with so many outcomes, or we don't know what we are looking for, or we don't know we are treating. When the first thing about what we are treating, we know nowadays that diverse arachnoid cysts morphology indicate different pathophysiological origins. When we look by microscopy, finds the cysts remain they show fibrous tissue, sometimes with simple epithelial lines, sometimes with tissues, no arachnoid luminal epithelia, and we can discuss various cysts types with various different tissues type. It can explain because it can explain why some cysts can present with different evaluations. This paper was by the Childs in 2023, and they say the same. And they say the same thing. When intracranial drainage versus extracranial shunt in the treatment for intracranial arachnoid cysts show that there are not statistically significant in clinical symptoms improvement. Maybe we are not choosing the best technique for these patients, or like when we will talk about the arachnoid cysts in temporal fossa, we don't know what we are looking for. Here we have the advantages and disadvantages for the different surgical techniques: shunting, cyst shunting, ventricular shunting, microsurgical cyst excision, endoscopic fenestration, marsupialization. The interesting for this table is not the advantages or disadvantages, is that even for 1, 2, 3, 4, 5 procedures, we have a lot of disadvantages for all these procedures for the same pathology. This is the most common arachnoid cyst in pediatric population. That's the cyst from the middle cranial fossa. This is just for show that we have Gallus 1, Gallus 2, and Gallus 3 or 4. Depends what we are looking for again. Type 1, it's very limited to the anterior portion of the middle fossa. Type 2, a triangular or quadrilateral shape, with occupies the anterior and the central part of the middle fossa, extending along the fissure, the Sylvian fissure. And the type 3, large, oval, or rounded, occupying the middle fossa in almost an extension toward the cerebral hemispheres. Even for this Gallus 3 and Gallus 2, we know that the endoscopy may be not the best technique for everyone. This case, that's a boy with 8 years old that we operated last year with a progressive headache, vomits after fall from hammock. He was admitted in the hospital of Glasgow 15, no neurological deficits, and a very strong headaches. Here we use the measure of the compliance, the cerebral compliance. It was interesting that when we use this device, the B4K, for his cerebral compliance, when we put the children sitting, we saw an inversion from the relationships between the P1 wave and P12 and P2 wave. When he was in line, the relationship for the compliance, the cerebral compliance was physiological. When he sit, it was an inversion for this cerebral compliance, and for us is important because it seems for us and that was cerebral hypertension, intracranial hypertension. We have three cardinal aspects. I'm sorry for this. Okay, no problem. For decision make, need for wide fenestration, risk of subdural effusions, and risk of venous hemorrhage and cranial nerve injuries. That's what we think when we're looking for a temporal arachnoid cystis. In patients with large middle fossa cysts, especially we know, especially in these children that younger than 2 years, the effusions are more common than because the rapid drop intracystic pressure after the surgical fenestration would cause, in the dictionary of increase of CSF production, a regional change with closure of the communication between the cysts and the bowel cysts and the basal systems. A combination of this phenomenon with an immature mechanism of absorption in the children younger than 2 years old, because they don't use arachnoid villi, but a system in the basal cranium. Conditions we have conditions for the appearance of subdural effusion or hydrocephalus. So we always consider the possibility of shunting early in this population, even in microsurgery or neuroendoscopic fenestrations. Another thing that we look for in this case in an MRI, we observe if we have thicker cyst walls in the region adjacent to the basal cisterns that we can visualize in MRI, because these thicker cysts are associated with the presence of several successive membranes, great opacity and less transparency of the related neurovascular structures. So we have an increased risk for venous bleeding and reocclusion of the fenestration. In this case, normally we use the combination microsurgery approach by keyhole and neuroendoscope in the cysts in this patients. The objective always is fenestration of three membranes: optocarotid, oculocarotid, and oculotentorial. The need for wide fenestration is clear for us, and these three membranes, at least we need to open two membranes of the three. The recurrence rate is higher in those with cystocysternostomy. If we don't fenestrate two membranes, I'm sorry, it's the risk if we fenestrate just one membrane. Wide fenestration is seen if it's open more than one membrane. And we need to see we need to open the three membranes and direct visualization of the basilar artery. The risk of recurrence is very low. It's lower than in another case. This case, and we know that the fenestration is really open when you see the flow void sign in Q2 and T2 weight imaging in the MRI. This is the case of the patients, and we think that it was sufficient for him. The suprasellar arachnoid cystis, we can imagine, okay, we are talking about arachnoid cystis. It's completely different from the temporal cyst. The suprasellar arachnoid cystis, they are from the pontine region, displacing the optic chiasma anteriorly and the third ventricle superiorly, maybe from a cystic dilatation of the interpendicular cistern or of the intrarachnoid region of the liliquis diencephalic membrane. Different from the middle fossa cystis after the 50s, cystoperitoneal shunt was the method of choice when compared to open microsurgery until neuroendoscopy techniques from the 2000. The treatment was really different after I'd like to move on the video. Okay, just this is a case that we think that open the cyst we like to open in L form, a wide L form, not just Fogarty catheter. And our objective is to observe the interpeduncular cistern. We know that when we have a rate of recurrence higher when we just make the ventricular cystostomy. The explanations for the high failure rate in this type of surgery, neuroendoscopic surgery, that we can formation of a ciliary membrane in the superior fenestration collapse to the cyst. The cyst fluid exiting through the inferior cistern route in the ventricular cystocystostomy. And what we look for successful criteria in suprasellar arachnoid cysts. A cyst wall shrinkage, and pontine anatomic reformation in the post-op MRI, in the mammillary bodies and optic tract horizontalization in MRI post-op. This is what we look for in these patients. This is for us is always necessary. Open the liliquis membrane and really see the pontine, the interpendicular cistern. But even with the neuroendoscope technique for suprasellar arachnoid cysts, that we know the better technique for the cysts, the team from Necker published this paper that's very interesting about a simple classification for supracellular arachnoid cyst in type 1, type 2, and type 3. And the management may be different. We are talking about supracellular arachnoid cysts. The features, extension, and diagnosis sometimes different, and the management is different too, showing us that in neuroendoscopy tech is not for everyone. For the intraventricular arachnoid cysts, they are rare. And for us, it's very, we have, because we have a lot of premature babies here, or even congenital infections here in our region, in our country. It's not so rare for us. It's in the past, these patients were operated by shunt, but for me, normally I use a neuroendoscopic technique for all these patients. We have at least 16, 50, 60% of success in these patients. We operate normally, usually in the first or second month of life. We don't know yet what kind of patients will more benefit, but we observe that for the neuroglial cysts in the frontal lobe, the successful rate was not better than occipital or parietal intraventricular arachnoid cysts. They originate from vascular mesenchyma, or in some cases as an extension of the subarachnoid arachnoid cyst through the choroidal fissure or into the lateral ventricle. They are most frequently encountered in the trigon and the trigon of the lateral ventricles, like this case that we operated this case last week. And our objective is cyst drainage, cystoventriculostomy, marsupialization, and ETV for all these patients. This is unilateral congenital obstruction of foramen of Monro. That we observed the obstructed monoforamen here. We talked first make a septostomy together, but when we discovered the foramen of Monro completely occluded with a thin membrane in the walls of the lateral ventricle, it was not sign of hemorrhage or infections. This is really congenital obstruction. We saw by transparency the plexus, the choroid plexus here. And using the set of material for endoscopy, we like to use this pins we call deck. We really use it a lot because make small fenestrations and safe fenestrations for after we use Fogat or scissors. In very young patients, this patient has 2 months old. Usually we don't like to use scissors or bipolar. We just use deck and Fogat. we think for this patients, we know that the membranes in these patients are more elastic and without great vascularization, so it's easier for us make these procedures without scissors, without coagulation, and after this we make the ETV here. Okay, let's go on. Let's move on. And we have some case that we don't know yet the origin of this case. So we don't know, even when we don't know the origin of this case, we can choose the technique when we separate the brain in superficial cysts, cortical cysts, and profound and basal cysts. It's not difficult for us to think about it. This case was a baby with a ventricular asymmetry at 36 weeks pregnancy, and we operated with 3 months old. Maybe a cyst of the foramen of Monro, persistence of cerebral diverticular from the wall of forebrain. After lateral ventricles appearance in the end of first trimester, we don't know if it was the case, but we choose a cystoventriculostomy plus ATV. That's what we think always in this kind of patients. We always make ETV in these patients. This is the foramen magnum with the cysts and septal vein, arachnoid choroid plexus, and a cyst that occlude completely the foramen of Monro. That's something that we like to use in these patients, that we like to navigate in the ventricles with the flush of water open and close it, open and close it. When we need to move cysts, sometimes to move some structures, we open the flush of water, and the flush of water make the structures go please lateral for one side or lateral for other side, and we can navigate after this, and we close the flush of water. Because in young patients and young children, usually the walls are not so thick of the cysts, and we can, with the water flush, we can manipulate the system, we can navigate in the lateral of the structures. So we open the cyst walls, and we made the endoscopy third ventriculostomy. In our region, this kind of patients, if this baby is not with the pediatric neurosurgery, the treatment is shunt. 10% of these patients are made by shunt. Intraventricular arachnoid, simple intraventricular arachnoid cysts, temporal fossa cysts, this kind of foramen of Monro congenital arachnoid cysts, all these cases are operated by shunt. So for us, can use this technique without shunt, even for 50% of successful. I think it's a good alternative. That's a presentation more for discussion, more for make some reflections, because I'm sure that in this panelists table, I'm the worst of you. And I just wanted to propose questions for other neurosurgeons and young neurosurgeons in the world to think that the technology is not the best alternative ever for all the cases. We need to know what we are doing, what we are looking for, and what we are waiting for after choosing the best technique. Thank you, everybody. Namaste for you.
Thank you, Professor Thiago. I think you gave us an extensive overview of the topic, the issues in the decision making, and the various complexities. And I think you have made it clear that it is a conundrum in the beginning and conundrum towards the end. I'll start off with some basic questions. One is, let's say, as you said, the most common one is the middle fossa arachnoid cyst. Now, how would you, I mean, Galaxy 3 is very obvious to decide, you want to operate them anyway. How about 1 and 2? How do you decide? How do you decide a decision when to treat them between 1 and 2?
That's a great question, because mainly for the temporal arachnoid cysts, even today, we don't know what we are looking for, what we are treating. For us, arachnoid cysts for the temporal fossa, we need to treat for intracranial hypertension. Arachnoids, Galaxy type 1, we don't operate. Type 2, I really don't have experience for this cysts because they are not with us. I have some type 2 in the we have consultations, type 2 for headaches, scholar difficulty, epilepsy. We don't know that if we operate these patients, this condition will be better. For us, the type 3 with clear sign of intracranial hypertension.
Do the other panelists want to comment on it? Type 1 and type 2, how do you make decisions on when to operate?
Suhas, can I?
Please.
Yes, the question, I think you made a very valid point. As far as type 1 is concerned, there is no doubt there is probably no indication for surgery. For type 3, obviously, surgery is indicated. The problem arises in Galaxy type 2. Especially what happens is if the child has 1 or 2 episodes of seizure which are under control, and the boy or girl goes to school, and the parents tell you that the scholastic performance is less than their elder sibling or something like that. So then there's a general psychological pressure from the parent side, whether the treatment of this cyst will lead to improvement in the school performance. I don't think, to the best of my knowledge, there is not enough evidence in the literature to suggest that treating Galaxy type 2 cyst will lead to improvement of scholastic performance. But I don't really have a large experience with middle cranial fossa arachnoid cyst. So I would like to know the opinion, your opinion, and probably the opinion of other panelists, including the presenter and Dr. Dirako.
I think it's a very complex indication to operate this kind of a cyst. First of all the clinical symptomatology is not really the cause of because of the cyst. Epilepsy is often coming from the other temporal lobe, not on the side of the cyst. Headache is a very common problem, and it's not specific of the cyst. I think that the most important problem is the age. If you have a cyst in a very young children, a large cyst, sign of increased intracranial pressure, then you should operate to avoid some kind of a development anomaly of the brain that has not place to develop because of the cyst. But when you have a child of 7, 8 years of age, all the signs that are used for the indication probably are not really existing, because they are signs of the accommodation of the brain to the presence of the cyst. So when you operate, often you change the equilibrium that the brain has reached in the course of the year. And then you have a problem. You have often hydrocephalus, you put a shunt, the shunt causes dependency in these patients very often, very severe dependency. I have 2 cases that lost the vision because of the shunt malfunction that we don't have in other types of shunting procedures. So I think that we have to decrease the indication to operate these children. They look easy. They stimulate the macho attitude of the surgeon, but often the operation is not necessary, in my opinion.
Thank you, Dr. My second question was regarding the treatment options. You want to use shunt for the, you said you wanted to use shunt for the youngest kid. My basic question is, what kind of shunt would you ask for? Let's say you have a child with arachnoid cyst with subdural space, large subdural space, and you want to do a subdural peritoneal shunt or a direct cystoperitoneal shunt. What kind of shunt would you use? And how do you make, if it's programmed? I mean, there are options of programmable. And how do you change, play with the program, the programming of the particular valve, if it's programmable?
Personally, I would avoid to put a shunt in an arachnoid cyst. And I don't see any indication for shunting. In the past, was used to have the cyst ventricular system. And this could have a logical. But nowadays, you can use endoscope like Dr. Cavalcante showed, more effective than put a shunt in between the cyst and the ventricle. And the only cyst that should be operated for me is the supracellular cyst. This should be operated and correctly should be opened into the ventricle or into the basilar system. But the temporal, as I said, some cases we should not operate, while other, the quadrigeminal system cyst can give some difficult epilepsy sometimes. So we put all together in the same title, arachnoid cyst, but actually arachnoid is normal structures. So what differentiate in the location is not the cause, the cyst itself, but the place where the cyst develops. So we have a different indication according to the region where the cyst is. And for me, the most difficult is posterior fossa cyst, in which is very often is confused rhatic cyst or other kind of a cyst, and true arachnoid cysts are very rare. And so often there are done mistakes in this. But it's a lesion that neurosurgeons like to operate because it seems an easy operation. And sometimes the result is impressive. The brain expands. But in most cases, the brain does not respond to the opening of the cyst. And you have other type of problem. Like you said, you can have subdural fluid effusions that are difficult to treat. And then in this case, as you said, you have to put the subdural shunt system, subdural peritoneal shunt system, which stay for some years before you can remove. So sometimes we do more problems than we solve.
Do you use the option of programmable shunts in these children?
Sorry?
Use the option of programmable shunts?
Double shunt? What do you mean?
Yeah, programmable shunts, yeah.
I don't know what you mean. Shunt between
Yeah,
the
no.
the ventricle.
Yeah, whenever you want to use a shunt, do you want to give an option of programmable shunts in these children? Programmable shunts?
There are people that use a programmable shunts. They were introduced by Motorese in France in the opening that you could expand the brain gradually, so avoiding the shift of the brain and so on. But he did, but it was never demonstrated that a programmable shunts was working better than other shunts. As I said, I would avoid shunts. If I can suggest you, try to avoid shunts in arachnoid cyst. I think that Carol Kanter thinks the same, and Professor Muthukumar, I think they agree that it's better not to use shunt if we can.
Professor Tiago, Dr. Muthukumar, do you have any?
Yes, it's very important. Listen, Professor Di Rocco, for two things. The first, that Professor Di Rocco is the loop of the knowledge evolution for the arachnoid cysts. He started to talk to us about arachnoid cysts in the 70s, 80s, and he looked at no shunts for these patients. And the second thing, that when we read papers about procedures in arachnoid systems, mainly for temporal cysts, we need to ask who is the neurosurgeon. If we are talking about a pediatric neurosurgeon, the evaluation successful needs to be more than 5 years, not 1 year or 2 years. If I operate arachnoid cysts with shunt or microsurgery, principally shunt and intracranial drainage, all the 3 procedures have good, higher successful rate for clinical improvement, but not for more than 2 or 3 years. For a neurosurgeon that doesn't work with children, okay, maybe it's not a problem. The patient is have shunt dependence, but for the pediatric neurosurgeon that we are with the patients for 5, 10, all the life, more the shunt after 3 or 5 years, the rate of unsuccessful in obstruction, it's very high. So really better no shunt arachnoid cysts. For 1 year, 2 years, okay, it's good. More than 3 years, no. We need to operate this patient, and shunt dependence is a really tough problem for the patients and for the family, for us also.
If it's interesting in the Congress when people show the cyst before after operation, almost error is quite the same, just some enlarging of the system. And they say, see, the cyst is reduced. It's really not to do anything for the patient. Secondly, for the shunt, you agree. I agree with you, because when you put a shunt in a cyst, often the membrane of the cyst itself go around the shunt. And after a while, after 3 or 4 years, like you say, the shunt is occluded by the membrane of the cyst. And to remove this is quite difficult because it's attached and sometimes can give the problem. So if we can avoid the operation, it's better. Follow the child for 1, 2, 3 years. If it does not change, there are not clear symptoms of increased intracranial pressure, probably they can go around for all the life. And one reason for operate that was claimed by several people is that you can have bleeding from the wall of the cyst in case of a trauma. So a reason to remove the cyst wall. But actually, you can have a bleeding in children that have been operated on, they have had the injury, and still you have bleeding. So it's not because of the cyst, it's because of the brain. It's not occupying all the space, has a very large space around. So in case of a trauma, you can have a movement of the brain and the bleeding from the veins that attach the brain to the skull. So it's not really preventing post-traumatic bleeding the reason to operate the cyst. But it still is an open pathology for discussion. I agree.
So I think that just two quick comments, if time permits. I particularly like one of Dr. Tiago's slides where he said that if there are multiple options for a particular condition, that means we have not found the ideal option, or probably we have not understood the disease. I think it's a very valid statement. More than 30 years ago, my teacher taught me that for any neurosurgical disease, if there is more than one option, treatment option, no one option is ideal for all patients with the same disease. I think it's extremely relevant for arachnoid cyst, extremely relevant for arachnoid cyst. And the second point I would like to highlight is somewhere in the 90s, there was a beautiful article about CT cysternography from Japan in arachnoid cyst. I think that is something that has been totally neglected in the neurosurgery literature, where they showed in certain patients with arachnoid cyst, irrespective of the location, most often in the Sylvian fissure or middle cranial fossa arachnoid cyst, in the vicinity of the arachnoid cyst, the CSF circulation is disturbed. Now, they found that, I can't remember the center, but it was in surgical neurology at the time. So those patients in whom the CSF circulation in the cisterns around the arachnoid cyst was normal, when they fenestrated the cyst into the cistern, those patients improved. The recurrence rate was high in those patients in whom the CSF circulation and the adjacent cistern was abnormal. So this is something which I think neurosurgery literature and neurosurgeons, we have completely ignored. We are looking only at the cyst. We are not looking at the CSF circulation in the cistern adjacent to the cyst. Because I believe the success or failure of endoscopic fenestration or microsurgical fenestration, whatever it is, entirely depends upon whether the cistern into which you drain the cyst has a normal CSF circulation. And we have now MRI techniques like time-slip MRI to find out whether this circulation is normal. I think further studies are required.
Thank you, Dr. Kumar. Thank you.
Yeah, I partially agree on this, because when you use the metrizamide to show these kind of things, it was depending on the time. If you did the control exam 1 hour after, the cyst was excluded. But if you did the same in the same patients 6 hours or the 8 hours after, often the contrast entering the cyst. And I think that there is a kind of a communication between cerebrospinal fluid and the cyst, slowly, but still exist. Otherwise, the cyst should not enlarge. And what you say is correct. If the cyst is impeding the circulation in the cistern that are anatomically connected to that cyst, specific cyst, then remove the obstacle can be useful for the patients. I agree completely. But if the cyst just maintain the brain in place, and there is no any obstacle in the circulation around, as often occurs in Sylvian arachnoid cyst, then if you operate, you can create a disequilibrium, because abruptly you change everything, and then you can have a problem. So this study that you mentioned can be useful, but should be extended for all the day, the exam, to understand the rate of infusion into the cyst. So this is probably the reason for which is not used so much, because it takes 1 day for one single patient.
Professor, there is a person by name Shin Yamada in Japan. I think he gave a lecture in one of our ISPN conferences in Kobe, where he showed these time slip MRI sequences where the CF circulation behaves in a totally different way than what we have been taught. So that after listening to that lecture, that has completely changed my concept of CF circulation. So I think time slip MRI sequences, I don't think it is possible in all MRI machines, but if it is possible, I think it should be done. Maybe there's a scope for doing that. Something which we should look at the CSF circulation in the vicinity of the arachnoid cyst.
My idea is that does not exist a circulation of a fluid. And this is a concept of 100 years ago, worked well for the neurosurgeon that had to put a shunt like this, but really does not exist for me. What I think is that the fluid moves in the brain everywhere, and it moves from an area of a measure pressure to area of a less resistance, but it's a kind of equilibrium. So the presence of the cyst can be just indifferent for the brain if does not interfere with this movement.
Oh.
And I have actually one case in which we left because the cyst made the bleeding terrible and the brain collapsed. We put a lot of fibrin material. We made a kind of a mass. The child survived. He has still this mass in the place of the cyst, and it's perfectly okay because this material is not absorbed and probably has been insulated by some kind of a reaction of the membrane and sustain the brain. So in most cases, this cyst just maintains the brain in place. And the idea that blocks the circulation of the block just the free movement inside the hemisphere. But if the fluid can go around and they go in the virtual space and the cyst does not do any problem to the brain. And we have to change idea in the future about the circulation with this glycolymphatic system, which are probably space. So probably we are still influenced by then the ideas, but it's time that we change.
Thank you, Rocco. Thank you. Dr. Tiago, you had something?
About Professor Di Rocco talk said we agree because we started to study the pediatric neurosurgeon with a device that we make the measure of the cerebral compliance. We call Breathe for Care, and what we are finding that's the problem. That's not the cyst, but the circulation. The movement. Perfect. Thank you. The movement around the brain. When you use the Brain for Care for that patient with arachnoid cysts, it showed that was the compliance, the brain compliance is not good in that moment. But the compliance, the cerebral compliance, we make the measure in all the brain because the movement is like that. The device make this, and after the surgery, in another place for the cyst, the compliance, the brain compliance was normal. So that's for us, that's not the cyst, but the movement. That's the movement.
If the cyst is very large, probably the effect is on the brain. But if the cyst is still acceptable for the brain does not care, it's useful to have the cyst there. Because if the brain does not expand after you have too much shift over the brain.
That's why the indications for surgery for us are not a lot of indications. That's how you said headaches, epilepsy. We need to make changement in all the dynamic of fluid movement.
Only the supracellular cyst should be operated without any doubt.
Yes.
So we arrive to the same conclusion. It's nice. It's rare and nice.
Thank you. Thank you. Dr. Boone, do we have time?
Yeah, we can have a few more questions. May I ask two questions, Professor? Can I say that because of the poor brain compliance, sometimes probably because of delay surgery, the response not so good. But how about those despite fenestration, we still see a midline shift? Do you think there's a compartmentalization within one cerebral hemisphere compared to the other one, beside the poor compliance of abnormal side of the brain? And then, Professor, another question that I would like to ask regarding ETV in neonate. Generally, we know that ETV success rate are low in neonate. So would Arachnoid cyst problem make a difference for ETV in neonate, Professor?
Yeah. The last question, I think, is more the easiest in the sense that the brain movement in the brain is not related to the production and the absorption. It are related to the ability of the subarachnoid space to allow movement of the fluid. And the subarachnoid space of the brain probably in the neonates are not so efficient. The mechanisms are different from the adult. And another example, just the opposite, you have a normal pressure hydrocephalus in which you don't have any problem in circulation, but still you have hydrocephalus because the subarachnoid space are no more able to absorb probably. And in the neonates, you have the same problem. So when you open the way with the ATV, the subarachnoid space around is not able to absorb. So, and for this reason, that's not. It takes about 1 year and more to maturate the subarachnoid space to be absorbed. So this is a reason, because it does not work. So, the other question, I don't remember. The first question was?
Regarding compartmentalization within one cerebral hemisphere compared to other, because sometimes after the drainage, the shift is still there. Do you think that, like what Prof. Tiago has said, the problem is not with the cyst, but the whole cerebral hemisphere, probably unilateral problem, that the disconnection is between left and right brain? Do that with that concept help us to equilibrate, correct the equilibrium?
Probably. I prefer to have two normal hemispheres than have one with a cyst. I agree. So some problems should be given, but it's every time also question of time. See the posterior fossa tumor. You can have a case in which you have a big tumor or small tumors, and abruptly you have hydrocephalus, increased intracranial pressure. Then you have patients which you have the same tumor that occludes the aqueduct, and there is no hydrocephalus. So it means that if you have time to adjust, the tumor is growing slowly compared to the other one, then the brain can even not develop hydrocephalus, even when the aqueduct is completely blocked. In your practice, you have a lot of cases in which posterior fossa tumor don't give hydrocephalus, which should be, but no, because it was an astrocytoma, grows slowly, and then the brain adapts. Again, for the cyst in the posterior fossa, you can have a lot of cyst in the posterior fossa, or having the cisterna magna divided into 3 segments very large, but you don't have hydrocephalus. So I think it's a matter of time. If the obstruction is occurring slowly, the brain can adapt, the compliance can be maintained at least to a certain extent. So I think it's matter of time in which the occupying space lesion develop. And the cyst probably takes a lot of time. So for this reason, can be accepted more than a tumor.
Thank you, Professor.
Do you have time, or can we have more questions?
Yes, we can. If there's
Okay.
a question, Prof.
So I have one more question. I mean, when you have a middle fossa arachnoid cyst which is extending over the convexity, a very large arachnoid cyst like the one which you showed, where do you put the burr hole? Because you said you want to visualize the basilar artery, isn't it? So where do you put the burr hole?
Yeah, I have a very bad experience with this hemispheric cyst. And bad experience because when you either open or put a shunt, generally the brain does not expand. So you remain with a large cavity, maybe a little less than before the operation, but still a large cavities on the brain surface. So the brain remains with this excess of the liquid that decreases the compliance of this hemisphere. So you don't really improve the patients. And often even the skull bone cannot remain in the same place. Theoretically, you should decrease the space, make it smaller the vault of the skull. But this will be not so accepted by the family, because then you have just the opposite. You have an asymmetrical skull with a small skull on one side, a larger on the other controller. So the family don't understand anything. So it's the only good thing is that these cysts are rare, but I agree with Dr. Muthukumar that in this case you have to think really which option you have, to try a shunt or to open, but in my experience they don't do well. I don't know if TI was a better experience than me, but these large hemispheric cysts are difficult to manage.
Dr. Diego?
Are rare. They're lucky.
You're muted. You're muted. Your voice is. Dr. Diego, your voice.
Yes, I'm sorry. It's obvious that I'm not more experienced than you, Professor. But it's a question for two things in this discussion. The first, that when we started to study the brain compliance with the brain for care, we observed that we started to make the use of the device for measure of brain cerebral compliance in patients pre and post cranioplasty. And we observed, and we started to observe that in the other side of the cranioplasty, the brain compliance was worse in the post-surgery than before surgery, showing that if we have time for the CSF movement in the brain, it's better. The patient goes better. The second, yes, the second is a question for you. Since for the last 5 years, in 2018, we started to operate the great cysts, hemispheric and temporal cysts. We started to make not a borehole, but a small craniotomy, a mini craniotomy, and we started to suture the arachnoid in the...
To reduce.
Yes, we start to suture it and make, and after we go with the endoscope and the subdural effusions. For us, we don't have more subdural effusions. For the families, for us, it's more simple simple. Understand that the cyst is the same size, but subdural effusions, even the child goes better. The subdural effusion is not good to look in the MRI. So when we started to make the shooters around the arachnoid and the duramer, I don't know in English, the subdural effusion goes down substantially.
For this system, maybe what saying Professor Sui asked for, the use of the programmable valve could have an indication to try to decrease slowly the cyst. This can be. But if you do this kind of operation, why don't you use the dura membrane to reduce the volume? So without opening the dura, you can engage the dura directly and then leave a space that is not accessible to the fluid, so you don't have a subdural effusion. Maybe you can try this to reduce, to touch the dura mater rather than the arachnoid. Because often when they have the subdural effusion, children are doing quite badly. They have a headache, vomiting that they did not have before. So the subdural effusion is less well tolerated in some case than the cyst itself. So why don't try with the dura mater to reduce, like we do sometimes after removing a bigger tumor, that when you close, you reduce the dura. That could be an idea to try.
I will do this. It's a very good idea, Professor. Thank you.
By the way, I had operated very lot of temporal arachnoid cysts, but a few years ago, I published a paper. We do operate this, but should we do? So now I'm a kind of a sinner that said, my fault. Maybe I should not have operated so many cases. So
yes.
I'm not a good example for this.
One more question which I had was, in a pure convex T arachnoid cyst, is there a role for endoscopy? A pure convex T arachnoid cyst.
A pure?
Convex T arachnoid cyst, which is not extending towards the cistern. Is there a role for endoscopy?
I didn't get the question. I have some problem with the audio. Sorry.
No, the arachnoid
cyst that is without inside the brain,
extending on the convex.
Not connected to the cistern.
Yeah, which is only on the convex.
A porencephalic cyst.
No. One which is extending only on the convexity of the brain. An arachnoid cyst extending only on the convexity. Like we have a frontal arachnoid cyst, we have a parietal arachnoid cyst, which not extend towards the cistern. Is there a role for endoscopy there?
Actually, when you have a small cyst over the brain, like a parietal cyst, we operate them because often they gave epilepsy. But removing the bone, opening the cyst, sometimes putting the bone vice versa to reduce the residual volume, worked very well. But I don't have experience with endoscopy in this cyst because we went to operate it because of the epilepsy. So we wanted to remove the local pressure directly. I don't have experience with endoscopy. So maybe the other area, but I don't have. What we did were small parietal bone flap, opening the arachnoid very large, removing, and then eventually modifying the bone flap, maybe some change in shape or even inverting, and then the results were very good for the epilepsy and the non-recurrence of the cyst. So this kind of enlarging focal space, I think, are not really arachnoid cysts, are some focal enlargement of the arachnoid that represent the problem of a movement of fluid in that region, compress the brain sometimes strongly because they are very compact, very heavy pressure. They give epilepsy as a kind of a irritating agent on the cerebral convexity. So removing this pouch of the arachnoid works very well. So, but I never did a bioendoscope.
What about interhemispheric arachnoids? Interhemispheric arachnoids, what's the ideal management? Because in interhemispheric, it's very troublesome condition to operate this. Shunts don't function, you don't have much place to fenestrate, and that's a condition which I don't like to deal with.
Yeah, these are, it's a very interesting question because we have different types of interhemispheric arachnoid cysts, and they should, as you said before, evaluate very well before, because we can have a cyst that without any agenesis of the corpus callosum, so cysts that remain between one hemisphere and the falx. But then we can have a cyst that are associated with agenesis, partial agenesis of the corpus callosum, and then we can have a cyst that was shown before by Tiago, that is coming from the foramen of Moreau, let's say, going towards the suprapineal region and then developing in the interhemispheric region. So 3 different types. And the first one should be removed, removing the membrane endoscopically open. The second, for me, is that should be put in communication with the other ventricle, so to have free movement. The third one is probably a normal arachnoid cyst, but often this cyst have a recurrence, and you have to operate 2 or 3 times to decrease progressively. We had a patient that were operated 2 or 3 times, and at the end remained a kind of a cyst, less than the beginning. They found another equilibrium, but are not really arachnoid, are maldevelopment cysts that associated also to some brain pathology. So for this reason, probably different patient to patient. But it's a difficult entity to recognize and treat. I agree.
Any more questions? Dr. Boone, anybody?
Okay.
I think there's no question. Probably Prof. Suhas, you can conclude the session, Professor.
I think for this session, it was very fortunate to have Professor Diroko and Professor Muthukumar, both of them very senior pediatric neurosurgeons with us, and with such a complex topic. As I think it was a great, it was more of a philosophical discussion rather than, I think the science is still lacking. That's very clear, and long way to go on this discussion and this issue. I think with this, I thank all my co-panelists, speaker, Professor Tiago, the co-panelist, Dr. Muthukumar, and Professor Diroko. Thank you very much, Professor Boone. Thank you. Can you take over? Yeah.
Yeah. Thank you. Thanks to Professor Suhas for chairing the second session, and Professor Tiago for a very fascinating lecture and a very good discussion. Ending to this today session, on behalf of the Education Committee of the ACNS and the President, Professor Yukato, I would like to thank both speakers of today, Professor Natarajan Muthukumar and Professor Tiago Kate, and also chairs of Professor Conselho Diroko and Professor Suhas Udaya Kumaran for the time and support for the SNS webinar. I would like to also express my sincere gratitude to Professor Zubin for broadcasting this webinar on WeChat channel. So until we meet again on 1st of April, is bye-bye from all of us. Thank you, Professor, and thank you all for joining.